Okay, let's start class. No, sorry. I'm guessing this is everyone. Okay, house rules. There's a few things. Quiz. Actually, it seems like you guys are doing very well. I'm surprised. So last year I gave the whole class like a whole week to do the quiz last year. Everyone got 100%, but the quiz everyone got 40%. So I'm doing it I'm putting more pressure on you now, so that you don't put too much pressure on yourself before the test. So this is a way around it. Some of you saying you struggle with the time for the quiz. Yes. So what time must I make the quiz? Not an hour. 45 minutes. I'll do 50 minutes max. Yes. Oi. That's a very good point. Okay, I'll do a 3-hour block, but I don't know when to put the 3-hour block. So when do you think I should put it? I'll ask Miss Wicha. Not Saturday. The class will murder me. I can't do Saturday. You guys will kill me. Friday, what time? Where's the class rep? Who's class rep? Please get a time for us. Try and figure out what time. Do you want to figure out what time? Hey. What time do you think? So yes, that's what I want. But I want you to tell me, because I can't get the answer from 200 people at once. Yes. Okay, I'm going to do it 12 till 3 this week. 12 till 3 this week. Okay, 12 to 4. Okay guys, I'm opening it up for longer now, 12 till 4. But don't misunderstand it. I don't want you guys to help. You can sit together and discuss in groups, but I don't want you to just screenshot your questions and send them to each other, because it really defeats the purpose. The purpose is to see if you are getting ready for the test. So the purpose of the participation really isn't so much to give you free marks. It's to force you to study for the test little bit at a time. Okay, so the idea isn't to give you 5 marks at all. I don't want to give you marks. I want you to earn marks. I just want to open this slide quickly, because it looks like you guys are actually doing very well, and I'm not sure how many of you are cheating at the moment. I won't get an answer, I know, but I'm just wondering. So if this is a true reflection, you guys are actually doing very well. If this is a true reflection, I'm very happy. So it means that some of you are doing very well, and some of you aren't doing anything. But I mean, at least now you can see you're not doing anything, and if you're one of those people, start doing something. I think there's enough resources. I can't make more resources. The other video of this morning will be uploading today, so it'll come up here sometime. And then I think we have to get to work. So the quiz this week will be from 12 till 4. It will be on pharmacokinetics, pharmacodynamics, and ADRs, today's work. So all 3 weeks' work will be quizzed Friday. Yes, I'm pushing you to push yourself. Yes. If I don't push you now, just let me just put a scenario out there for you. If I don't push you a little bit now, you'll get into the examination and you'll see, oh my word, I've got a participation mark or a CAM mark of 40, how will I ever pass? And then you probably stress yourself to death and maybe not even pass. So rather stress little bit throughout the year and too much all at once. Yes?
Possible that we can get feedback on the test.
What feedback do you want?
Like the quiz that I've done, if I go online I should be able to see
I think I will give you guys feedback, but only towards the end of the semester. Yeah, only towards the end. So for now, just keep up as best you can, and towards not the end of the semester, towards like a week in front of the test. So just before the test, I'll give you guys a lot of feedback around the quizzes, but I don't want to give it to you now. I want you now to just keep up with the work. Okay. Yes. The test doesn't cover a lot of things. The textbook. Are you feeling the textbook is not good enough?
Yes, me too.
Why? No, I mean, I'm not asking them exactly the same. I'm changing them, but the understanding remains the same.
Some of it is factual, like a word desensitization is a word that is there, defined in pharmacology. It's not something that you can just
Yeah, it is kind of. Okay, but I'll look into it a little bit later. Okay, guys, I want you guys to keep quiet. I don't want to struggle against you guys. So, give me examples. Write down examples on an email and send it to me.
I've sent you an email.
You have sent me email. Are you Ronke? Not Ronke. Okay, no, it's fine. I'll look at the emails. One more thing. A lot of you emailed me about one question not having a diagram. Yes. Don't worry. Okay, does it? Don't worry about it. I'll just remove that one. It's not an issue. It's a non-issue. If I give you, but remember, I'm putting these ones from pools. So a lot of people didn't get that question. So I can't give everyone 1 mark. Then some people have 105%. So no ways. No ways. Okay. So today we are discussing adverse drug reactions. I've done this lecture against the computer screen this morning, so I think I know everything I want to tell you guys today. It's once again information overload, but I'm going to try and simplify it as much as possible. And let's get started. So a lot of this should be making sense from pharmacokinetics and pharmacodynamics. So a lot of this I'm going to be discussing today ties in with what we already discussed. Okay, so the first part of this lecture is about routes of administration. And I think routes of administration, you guys told me you guys know a lot of things. Okay, so let me just clarify one very important thing from the start. So when we talk about systemic effect, so if I say a drug, yes, is it on? Yeah, it's on. Oh, it's on. So if I talk about a drug as a systemic effect, it means it's eliciting an effect or having an effect after it's been absorbed into my bloodstream. So I take a drug, I absorb it, it's having a systemic effect. Systemic effect means it's having an effect while it's in my bloodstream or while it's being distributed. If I talk about a topical effect, it means on the area I applied it or on the area where I administered it. So, something like an asthma inhaler, you know that thing? An asthma inhaler, do you think it has a systemic effect or do you think it has a topical effect? Are you sure? Yeah, it's topical. So, you could have a systemic effect if you have like 10 inhalations all at once, like then you would probably get a systemic effect. So if you have a very big dose, then you can get systemic effect, meaning you can get enough drug into your circulation to go and have an effect on a different place. But generally speaking, an asthma inhaler will be a topical effect. What about a cream? Of course, it's topical. It's on top, topical, yes, okay. And I think that's what I wanted to say here. I don't want to make it too complicated because there's a lot of slides today to cover. Anyways. I've discussed a little bit of this, I'll do it again. So, if you have a fungus infection on your skin, you know ringworm? I made a ring there, but it's come off now. But if you have a ringworm infection on your skin, you can do a topical cream there, then you might need altogether 3 milligrams. 3 milligrams of clotrimazole or ketoconazole can kill the fungus in that area. Or if you take it systemically, you might need to take 200 milligrams. And then you can get maybe 3 milligrams in that area. So do you see why we want topical effects? We need a lot less drug to get the same effect. If we can administer all drugs directly to the places they're supposed to work, we would do it. We just can't do it. Okay. And that's really all I want to talk about, topical and systemic. I think... Oh, no, it's not. So, we can get a systemic effect from something like a salbutamol asthma inhaler. So if I was taking an asthma inhaler and I repeated administration 20 times in a row very fast, do you think I can get a systemic effect? Why? It's a large dose. It's a large dose and your alveoli are massive. Like the surface area of your alveoli is massive. So I can then absorb enough of it to actually get some of it into my bloodstream where it can have a systemic effect. Does it make sense? So if I take a lot of salbutamol, for example, I might get enough absorbed in my bloodstream. And where does my blood move to from my lungs? Pulmonary artery goes where? The heart. Okay. And do you think your salbutamol can act on the beta-1 receptors on your heart? Kind of yes. So they can, in high doses, stimulate the beta-1 receptors and then they get tachycardia. Not hand clap, tachycardia. This is my heart. So then your heart can beat faster. So you can get a systemic effect from a topical drug if you have a big enough dose and you have a large enough surface area to absorb it. So another example is if I have burn wounds. Let's say I don't know what degree burn wounds, I still have intact skin. But let's say I have a massive burn wound over my body and I apply corticosteroids to that massive burn wound. Remember, if you have a burn wound, you have some local mediators, you have vasodilation happening there. The swollen skin itself has increased blood flow to that area. So if the blood flow is faster, the skin itself is damaged, more drug can travel through, and you might get systemic effect from applying it over a big area, and especially if that area is inflamed, because the blood flow to the area will be bigger. Does that make sense? So something like a burn wound or inflammation could lead to more drug being absorbed from a topical route into the systemic circulation. Is all of that making sense? Okay, let me not go into it further, then I'm definitely going to confuse you. Okay, and I think the first one is the oral route. How much do I want to say about the oral route? You know it's safest? Did you know it's the safest route? We've already said that earlier. Most economical route, yes, kind of. Do you know that the rate of absorption will vary a lot? Can you give me an example why it would vary a lot? Hey? First pass effect, that's the reason why it could vary a lot. Yes, first pass effect for sure. What other reason could the absorption? You took a dose and you took a dose. Both of you took a dose. Why would it not absorb the same in both of you right now? Maybe you ate McDonald's and you ate Roman's pizza. So it depends on your diet as well. The presence of food can change the rate of absorption as well. So the presence of food itself changes the rate of absorption. You can have some genetic factors. Some people might have different cytochrome enzymes within the gastrointestinal tract, and they could break down more of a drug before it gets into the bloodstream. So we have varying rates of absorption between different people based on diets and genetic anomalies and. Does that make sense? And then, when does the route become useless? So when is the oral route useless? What patient can you not give a tablet to? Unconscious patient, maybe a punchy patient, like one who doesn't want to listen to you. He'd rather punch you than swallow the tablet. so uncooperative is the right word. So people who are uncooperative. What about nauseous and vomiting? No. Can you still give it to them? Like you can't push through the vomit. You can't get it in then. Okay, get the idea. It's kind of logical if you think about it. Do I need to explain it a lot? I mean, it makes sense. When can you not swallow? The parenteral route, I think you guys understand the parenteral route quite well enough. Some good things about the parenteral route, very fast mode of action. The onset of action is very fast. It starts working very fast. It bypasses the first pass metabolism, bypasses varying absorption of the gut. It bypasses the deactivative enzymes in the body, or enzymes in the gut, so you can actually get more drug into the body. And then what's the big issue with bypassing the skin? Why do we have a skin? It's to protect us from outside. So if we bypass the skin, what's the bad thing about bypassing the skin? The thing that we're injecting must be clean. So clean. What's a different word for clean? Sterile, yeah. It must be completely sterile. Do you think it's cheap to make sterile things? Okay, there's an obvious disadvantage there. And then it has to also be isotonic. If it's not isotonic, it will destroy your red blood cells. Do you remember hypertonic, isotonic, hypotonic? Do you remember that? Okay, so it has to be isotonic as well. There's not much more I want to say about that. I want to simplify the dosage routes as much as possible. Oh, I discussed this as well. I want to grab something that could be an example. This is an example. Okay, so when we have a tablet, you guys, if you think about a tablet, what do you think of? Do you think about a white tablet, a shiny tablet, a green tablet, a pink tablet? Okay, most people think about the white tablet. So most of those grandpa-ish tablets are just compressed. So it's a bunch of powders that we take. So it might be different powders to break the tablet apart as soon as it comes into contact with water. A bunch of powders to make it bigger almost. Because remember, that active ingredient on the inside of the tablet is very small. Very small. So the active ingredient is like 100 milligrams. But the tablet itself weighs 600 milligrams. So that other 500 milligrams is just things compressed together to make the tablet bigger. So you can actually swallow it without too much issue. Then we can coat tablets. We can give them different coatings, like an enteric coating. Then it becomes shiny like this one. So when a tablet has an enteric coating, it doesn't dissolve within the stomach acid itself. It goes into the small intestine and dissolves there. So when we give a drug an enteric coating, we are protecting it against stomach acid. So it only dissolves at a higher pH in the small intestinal tract. Does that make sense? Yes. Do you think you can break it? Because as soon as you break it, that powder on the inside will be exposed to the stomach, the low pH of the stomach. Then some of the drug will be deactivated. So, second question, can we break all kinds of tablets? No. Obviously not, because we will then get more of the drug broken down before it's absorbed. Okay. We also get sugar-coated tablets, and I think they're probably harder than steel, so you can't even break them if you want to break them. If you can break them, you're probably very strong. What else do I want to mention here? I think all of that should be making sense. Then we also get drugs, these XDR, or not XDR, that's TB. We get extended release and prolonged release and all kinds of different release rates. Have you seen them? Yeah, you've never seen them. You guys are only second year. I always forget how young you are. I'm getting so much older all of a sudden. Anyways, so some drugs come in extended release formulations. So when you take a drug, you get absorption happening fast, and then you get metabolism, remember? So what if we formulate the drug in different layers? So the top layer, this layer here, disintegrates fast and gets absorbed. This second layer only disintegrates 3 hours later. This third layer only disintegrates 7 hours later. So what if we layer the tablet so it only disintegrates later, and then we get absorption happening later, and then the drug only becomes metabolized later? Okay, so we can create these extended release formulations, and there's a lot of examples of these ones. Do you think we can break this one? No, because as soon as we break it, we are basically completely taking away the extended release period, and we are releasing the middle section with all of the other sections all at once. So also, XDR tablets can never be broken, enteric coated tablets can never be broken, sugar-coated tablets can never be broken. Well, in theory, you can break sugar-coated tablets. It's just very difficult. They are too hard. You can use them for paintball guns if you want. I think they're just like, no, they're too small. Okay, oral tablets, all making sense. What's the difference between a capsule and a tablet? Not really much. I mean, the capsule just covers a powder. If you're using a tablet, it's just a bunch of powders put together, where a capsule just has the active ingredient on the inside. We also have different formulations where we actually enteric coat the powder or the little granules on the inside and put it in a capsule. But too much information, you don't need to know that. Advantages of the rectal route. If I had some LGBTQI, I would probably get a big reaction now. So tell me, what are the advantages of the rectal route? What is the rectal route? Do you guys actually call it the anal route? Okay, anyways, advantages. What's the advantages of it? Advantages of the rectal route. What if your baby is vomiting? Fast acting, kind of, yes, it actually is. So what's the advantages of the rectal route? What about reabsorption? It gets absorbed quickly, okay, so yes, in a certain sense it does. It's not extremely fast compared to intramuscular injection, but it's faster than oral, definitely. So what about unconscious patient? What about the unconscious baby? Aye? Yeah, if they're unconscious, yeah, they won't be able to swallow. Yes, but their butt can still swallow, so you can use the butt. So I mean, obviously, if a person is unconscious, done, dusted. Perfect example. What about if a person is having convulsions? Because I mean, we can still use the IV or the IM route, the intramuscular injection. So why would you opt for a dirty route if you can just use a needle? What if a person is having convulsions? Yeah, as you're trying to stab the person, you'll probably misstab and stab the wrong place 5 times before you actually get the right stabbing. So no, okay, so the rectal route, it bypasses the first pass metabolism, big advantage. You can use it for unconscious patients, you can use it for convulsive patients. and there's no, what do you call it, first pass effect. It bypasses the first pass effect. Disadvantages, you get something called leakage, so you can actually get some of it leaking out, which if you're going to go run the marathon afterwards, is probably not nice. So that's a disadvantage. It's kind of uncomfortable, I think. Probably uncomfortable is probably the main one you should think about. And that's all I can say about it. I can think of now. Okay. The sublingual and the buccal route, but you guys have heard about this as well. What is the sublingual route? Under the tongue. Can you think of a condition where it's needed? Where do you need it under the tongue? Dysphagia. Dysphagia, maybe. There's a bit of a problem there. I'll get to it now. So can you think of a condition where you have to use a sublingual route?
They're having an abortion and they put the tail under the...
Oh, the misoprostol.
Yeah.
Oh, they actually do that. I forgot about that. Okay, so I just heard about the misoprostol one. I can kind of remember that. I don't think it's actually the way it's supposed to be done, but I think that's the street evidence or the street information they get. But if you guys ever think about the sublingual route, I want you guys to think about fast acting and bypassing the first pass metabolism. Those are the two things you have to think about. And also, most drugs can't be formulated into the sublingual route. So you just spoke about dysphagia. So dysphagia is when you struggle to swallow. But most drugs can't get into your body with the sublingual route. So even if we could make them into a nice tasting formula, they can't actually cross the barriers inside your mouth. They can't get into your systemic circulation through your mouth. So most drugs that we can actually do this with are very lipophilic drugs. So the best example I want you to always remember is glycerol trinitrate, that one there. You know TNT? It's kind of like TNT. I think so, I can't remember now. It's kind of like the thing that they also put into condoms, did you know? Did you know they put glycerol trinitrate or some kind of nitrate into condoms? Did you know that? Some condoms actually have nitrates in, and nitrates actually dilate blood vessels. Why would you want to dilate blood vessels in the penis? Yes. So we have something called glycerol trinitrate. We put it into a tablet, a very small tablet, and we give it to some people who have angina attacks. Have you heard of an angina attack? So when you have an angina attack, you basically have a blockage of a coronary vessels. So if we can dilate that, we can bypass and we can get blood flowing to the heart again, so you don't get a heart attack. Does that make sense? So when we use the sublingual and buccal routes, when the drug can actually be absorbed from those areas, when we have one fast action and we want to bypass the first pass metabolism. But most drugs can't be formulated into the sublingual route. And of course, the side effects, the bad things is the bad taste that you will have, and you have to keep it in your mouth the whole time. You can't swallow it, blah, blah, blah. There's kind of logical things around it. Okay. Inhalation, I think we just spoke about the inhalation. What's the best thing about inhalation? If you have asthma, what makes inhalation the best? What's the best treatment for asthma? The best treatment for asthma is glucocorticoids, cortisone. You ever heard of cortisone? So do you know that cortisone can actually shut down your hormone production centers in your brain? It can completely shut it down. So if we give cortisone to you only in inhalations, you can get the good effects of cortisone in your lungs without getting the hormone shutdown everywhere else. So the good thing about the inhalation is that we can get localized effects, topical effects, only in the area where we want it, without getting the systemic bad effects. Making sense? Another advantage of it is locally acting. Well, of course, side effect wise, do you think you'll get a lot of side effects? If you don't get a lot of it absorbed into your body, do you think you'll get a lot of side effects? Not much. Very, very, very little. Very, very little. So of course that's also another advantage. The bad thing about it is not all drugs can be absorbed that way, and that's probably the worst thing about it. Everything. Oh, and of course the inhaler technique, the technique you need to use before you get an asthma pump in is actually very difficult. It's not just like there's a whole thing about it. You have to shake it. There's a whole thing. You don't just inhale quickly and get a good dose. There's a whole method you have to use to get a good dose in. So that's also probably one of the bad things about inhalations. I think we've gone into these ones enough. I don't want to mention them again. Also enough. I think Oh, there's one more thing I can mention, but I think you should definitely know a lot about this. What's the most dangerous thing that can happen to you when you get an IV catheter or an IV injection of something? What's the most dangerous thing that can happen? Infection for sure. Hey? You can't reverse the effect of the drug? Yes, definitely. Okay, so IVs are dangerous. We're agreeing so far, eh? IVs are dangerous. What's the worst thing that can happen when you get an IV? Because infection, you will die a little bit later. You might die of the overdose of a drug, but you might also not. What's the worst thing that can happen? Embolism. Have you heard of an embolism? Yes. Of course, if you get a pulmonary embolism, you can get a pulmonary infarction, meaning your lung dies. Or you can get a stroke, or you can get a blood clot traveling to your coronary arteries and get a heart attack. So embolism for sure the worst thing. Would you get an embolism easily? It kind of depends. But if you inject the wrong thing in IV, so if you inject something that's a TPN, or not a TPN, some kind of feed, nutritional feed that's actually very, it's an emulsion that's not supposed to go into your bloodstream, then you get an embolism forming quickly. So if you inject things in IV or via IV that should not be injected via IV, you have a very big risk of getting an embolism. Does that make sense? So the biggest and most dangerous thing about IV is about injecting the wrong things IV. Yes. So let me put it this way. You can actually inject quite a few air bubbles before it becomes a big issue. I'm not sure exactly how much, but most of the time the air bubbles won't do something. But if you inject enough air bubbles, you can actually get a blood clot forming where air bubble gets trapped in a certain sense. So where that blood clot starts forming, you can then get an embolism happening afterwards, if that makes sense. So I know there's actually an upper limit for how much air bubbles you can inject into a person, but I can't confidently say how much that is. I can't remember. Remember, the pharmacists, we don't inject a lot of drugs. We just talk about drugs. That's our thing. We talk about all kinds of drugs. Intrathecal, I think you guys have heard about the epidural before. So what would happen? Just a question quickly. I want to see if you guys understand it. I need a laser. Anyways, on top. What will happen if I inject this epidural there on top? What happens if I inject the epidural here? What does that mean? I'm falling backwards. What would happen if I inject the epidural on top, right there? Any ideas? If I had a laser, I would ask you now, but I don't have a laser. Any volunteers? I inject the epidural on top. What are these? The cervical ones. Cervical, thoracic, lumbal. So what if I do a cervical injection? Okay, I have an answer. What's the answer? No feeling? Yes. Hi? Yes, so from the section downwards you won't feel anything. So but what about all of those nerves that should be talking to your heart and your lungs? So what about all of those nerves that should actually be communicating? Because remember, your reflex to breathe comes from your medulla oblongata here, né? So if I suppress this piece of your spinal cord, would that message get to your lungs? Ah, you see. Okay, so you understand the idea behind that. That's why if we have an epidural, it's very low down. Yes?
It actually happened to my mom. Not the whole she shut down, but they put the epidural too high up, and then when she tried to mold me after giving birth, she couldn't.
Nothing.
The arms were numb.
So at least she didn't lose the wrong functions. She only lost motor functions. Okay, so it sounds terrible, but at least she only lost motor functions, not the other functions. So of course you're completely shutting down nerve transmission. So that drug doesn't decide I'm going to shut down only the somatic nervous system. It shuts down all the nervous systems. So none of those channels work. So none of those action potentials can be generated. So your entire nervous system is shut down onwards. Is that making sense? Okay. So intrathecal. What's the big disadvantage about intrathecal? You have to be specialized to actually inject it. I will never try injecting that in my life, even if you get no ways. I would never try it. So you have to be very specialized to actually do it. What's another disadvantage? Well, it's very deadly, very dangerous. So specialized, dangerous. What's the advantage about it? Well, painless birth, that's a big advantage. I'm not sure, I'm just talking about from what I've seen. It doesn't look fun. No one says anything. So a lot of you are becoming midwives after this, I'm guessing. Okay. Intrathecal, enough. What I want to discuss about dose adjustments. Oh, okay. So dosage adjustments. Oh yes, of course, I remember. So, okay, so we've discussed routes. Are you happy with routes? Is there anything about a route that you want to know before we move on? I'm not really into pharmaceutical chemistry, but I've got an idea. What about it? So the subcutaneous. Remember, your bloodstream goes everywhere. Okay, so your bloodstream connects with all of your body, gets some blood, ne? All of your body gets some blood for metabolic purposes. So your fat itself has, your fat layer, your subcutaneous layer, has blood flowing through it as well. So when I inject something into your subcutaneous space, I'm creating a little ball of fluid inside your fat there. And there are arteries running through that ball of fluid. And the drug will slowly diffuse into those arteries and be carried away. So eventually, if I inject it here, this little ball will be completely transported away and the drug will be distributed systemically from that area onward. Rub it. You can rub it. From a subcutaneous one. Heparin? Why did you get heparin? But why did you get heparin? Why did you get Clexane? Where did you get it? Why did you get a clot in your lung? Did you get it in hospital? But you seem too young to get a clot. Really, well, not too young. It's so weird. No, I don't think it matters actually. I don't think it would have mattered if you rubbed it or didn't rub it. No, I think the fact that you got a clot itself is actually, like, I mean, it's very weird. It's very weird that you got a clot in your age. So I think already. No, but the rubbing itself, most likely not contributing. Most likely not contributing. Okay. Yes.
What is transdermal?
Oh, I had a slide on it. I completely missed it. Where's my slide? There's it. So transdermal means through the skin. So we get some things, nicotine patches. Think about nicotine patches. You remember those adverts with the people putting nicotine patches everywhere if they want to stop smoking? So transdermal just means through the skin. So we have a lot of drugs that can actually be sticked onto you like a sticker, and then it travels through that sticker. So some stickers are made so they only release a small amount of drug over like 10 hours. So then when you put on the sticker, you've got coverage for 10 hours. We actually have something called Evra patches, and these patches contain progesterone only, and they are contraceptive patches. So if you stick them on once a week, they release enough progesterone to suppress your body's own production, and then you don't ovulate. It's making sense? So transdermal is through the skin. Big advantage of it is, I mean, you don't have to actually stab yourself, which is a bonus. It's a bit expensive, so it's much more expensive, and you would have to have a sticker on you for a long period of time. And of course, a lot of drugs can't be formulated in such a way that they can actually get into your body through a transdermal patch. A lot of drugs can't. And that's what I can think about. Any other questions? Oh, the implantation. It's also there. Have you heard of that thing called Implanon? Yeah, you must have. I mean, it's a big thing in government. So the Implanon itself is basically a tablet. Not a tablet. Tablet sounds horrible. So let's say it's a tablet. It's a kind of tablet that you implant into the skin. So it is a solid form. It's a solid form, and it contains enough progesterone to keep you progesterone filled for 3 months. So a year. Is the implant 3 years? 3 years. I didn't know it's 3 years. I thought it's shorter. Okay, so if you get an implant, let's say I give you an implant into your muscle, or it's in your butt, or I give you on your arm. If I give you that implant there, your body has to destroy that implant. As your body is destroying an implant and getting rid of it in that area, it's releasing a certain amount of drug. And that drug is then absorbed into your bloodstream and spread throughout. So from that area where it's implanted, it gets destroyed, partially, little by little. And the drug inside of that implant gets distributed throughout the body. And then you get the effect. Making sense? I don't know, it's 3 years. I thought it was like 3 months. Okay. Everyone happy now? Anything else about the routes you want to know?
Which one is the most painful?
Which one is the most painful? If you administer intramuscular one badly, it could be very painful. It's actually more down to your technique, I think. Yeah, like if you want to hurt someone, you probably can do it very well. Like if you want to use an 18 gauge needle to inject something, it's actually funny enough for 23 gauge. I mean, that would hurt. So I think it's down to technique mostly. Or if you inject and you turn and you pull out. Yes.
Technique is fine. Then which one?
I think the most painful one I think is IM, the ones that you guys administer. IM, I'm thinking. Intramuscular. I'm not 100% sure, but I think IM is the most painful. Yes.
Do you use the rectal route if someone has hemorrhoids?
Oh, that's a good question. So the question here in front is actually a very good question. A question here in front is, do you still continue using the rectal route if a person has hemorrhoids? Well, I think it will depend. If you can use something IV or IM, you would probably go IM. But if you have no choice, you go the rectal route. I know that the mainstay of treatment for hemorrhoids is basically local anesthetics, and then you use sherry pot. They call it sherry pot, but it's basically just a local anesthetic, and that is a suppository. So yeah, and I don't think we don't actually use suppositories so much for adults. It really is much more for children. So I think if you could avoid it in that case, you would try to avoid it. But if you can't avoid it, you can't avoid it. Okay. Everyone happy on dosage forms? Speak now, whoever hold your peace, and it's peace. Next section of the work, how much time have we been spending in class? Now we can continue. So I just want to, a small disclosure. I had class on the weekend, Saturday and Sunday, and I fell asleep, I think 6 times. I've got a new respect for you guys. It's difficult to stay awake in class. It's very difficult. So I had wine gums, and I just eat the wine gums the whole time. It's the only way I could stay awake. Especially if the person just like it's horrible. Anyways, dosage forms done, and now we're on to the drugs in the pharmacy itself, so the safety of the drugs. So generally speaking, all of the drugs that you guys will be dealing with throughout your life are very, 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 very safe. There are probably thousands and thousands and thousands of kinds of drugs out there, and there are many more that have never been approved. So all of those drugs in the pharmacy or in the clinic or in the hospital that you see there have been approved by an authority or a regulatory authority. We call the MCC. It was the Medicines Control Council, now it's South African Health Product Regulatory Association. You don't have to memorize that word, don't worry, we call it SAPRA. So SAPRA, if SAPRA says a drug is safe, it probably is very safe. So most of the drugs you guys will be dealing with have been accredited by SAPRA. So the ones that you will be dealing with are safe, you can say. And that being said, there are of course a lot of things that can go wrong dosage-wise. So most of the dosages recommended are safe, but if you have something like a liver failure or a kidney failure, or you have some genetic anomaly where you can't metabolize something fast enough, etc. We'll get into some of these as we go through now. A drug becomes dangerous. And of course, these will depend on a few things. So firstly, let's go into the biotransformation one. If a drug is metabolized by a liver enzyme and you do not produce that liver enzyme, will the drug be metabolized? Okay, if a drug is metabolized, will you get a very high concentration as you continue taking the drug? Yes. Will you get a toxic side effect? Yes, no, but let's go with yes. So most likely you probably will get something. So if you continue taking a drug and your body can't metabolize the drug, your chances of getting a toxic side effect is through the roof. What if you have kidney failure? What if you are diabetic and you have diabetic nephropathy? If you have diabetic nephropathy and you continue taking your metformin, you get a side effect called lactic acidosis. So of course, because they can't get rid of the drug, they get the toxic effect of the drug they were taking. And that is lactic acidosis for metformin. It's making sense. So you need to be able to get rid of the drug. That goes to biotransformation and excretion. Volume of distribution is a bit more difficult. So volume of distribution refers to the volume a drug distributes into. So the volume of distribution for alcohol is about 7 liters. So if you take alcohol distributes into 7 liters of your body fluid compartments. So if you think about alcohol, where do we measure it? If you hear on the news or you hear the new limit is 0.01, the brain. So do we then take a needle? Do we take a needle in a... Where do we measure it? If you're measuring your blood alcohol level, hey? Breathalyzer, but the breathalyzer is representing something. What is the breathalyzer representing? Your blood, yeah. So alcohol distributes throughout the bloodstream. So that's about 7 liters. So the volume of distribution for alcohol is about 7 liters. But a drug could be distributing through a bunch of other places. So some drugs have a apparent volume of distribution of 190 liters. Do you think you have 190 liters in your body? No. But when we take a blood sample from you and we calculate it, it seems like none of the drug is in your bloodstream and all of the drug went somewhere else. So according to that, we say apparently it seems that your volume of distribution for this drug is massive. Volume of distribution, I don't expect you guys to understand fully, but I want you guys to know that if your volume of distribution changes, your dosage must change. Where will you see this? Very, very sick patients. If a patient has been in a car accident, he was 70 kilograms, like me, he's 70 kilograms. He got into a car accident, he got a massive amount of damage, and he started getting edema. His ankles became this big, his lips swelled up this much, his entire face became swollen, everything is swollen, he's retaining water. So he was 70 kilograms when he came into hospital, critically ill, now he is 92 kilograms. Do you think his volume of distribution has changed? Yes, there's more water in his body now, so it might mean that the drug is now distributed through more water, so the concentration of the drug is actually decreased, so we need more drug to make up for that. So your volume of distribution for a drug can actually determine also how big your dosage must be. Okay, so I want you just to memorize that one for now. I think you'll see an example if you work in an ICU one day, but I won't ask you application kind of questions around volume of distribution. It's far too difficult. I still struggle to explain it to a lot of people in pharmacy, and they actually have to know it. So don't worry too much about that. And then of course, a patient's age and disease state. So just think about age. As you get older, your creatinine clearance, mine for example now is probably 110. When I'm 70 years old, my creatinine clearance will be something like 50. So as you get older, your metabolic function decreases, so you can't metabolize drugs as fast as you could when you were younger. So age plays a role in how fast you can metabolize drugs. Does that make sense? Disease state, we'll go with disease state, not much I want to say about that. Bioavailability, I think we've discussed enough. You guys remember what bioavailability is? So if I give you a drug that's 100 milligrams and no, I'm explaining it over again here. So if I give you 100 milligrams of propranolol and I measure in your bloodstream that you had 20 milligrams left in your bloodstream, what does that mean? It means that you lost some of the drug with the first pass effect. So bioavailability of the drug is actually like 40%. So the bioavailability is a drug that's available after absorption. So making sense? What will the bioavailability be of an IV drug? Okay, so you do understand, thank you. Okay, let's take a very small break and then we can continue again in literally 4 minutes. 4 minutes. Please stand up and walk around. I know how it feels to fall asleep. Walk around, walk around. Subaya.
Yeah, the one that I mentioned, but
Okay, let's finish. So hopefully some of you are awake now. Are you guys okay? Can we continue? Not can we continue, let's continue. Okay. Therapeutic index, what I want you to know about therapeutic index is that it's a measure of safety. If you know that therapeutic index is a measure of safety, you're probably okay. So as you can see on top, we've got a toxic dose and below we've got a therapeutic dose. So if your toxic dose is 1 gram and your therapeutic dose is 1 milligram, do you think the drug is very safe? It means that you have to take 1,000 doses of a drug before it actually is toxic. So in the case of paracetamol, for example, paracetamol's therapeutic index, paracetamol on top, I think the toxic dose is about 20 grams or 15 grams, so that's 30 tablets. So it's 15 grams on top, a toxic dose of paracetamol. And below then, a therapeutic dose of paracetamol is 500 milligrams. So it means that the therapeutic window is 30 times more. You need to have a therapeutic dose 30 times before you get a toxic dose. So if you take paracetamol, you put 30 together and take all 30 at once. Only then it becomes toxic. So do you understand what the window is here? The bigger the window is, the more happy you can be. So on top, we've got a toxic dose. Toxic dose is 15 grams. Below, we've got a therapeutic dose. Therapeutic dose is 500 milligrams. So we know that 500 milligrams goes into 15 grams 30 times. So it means your therapeutic window is about 30. So 30 is a very big number in therapeutic window words. So that means the drug is relatively very safe. Not relatively, the drug is very safe. Paracetamol is actually very devious. It's very deadly actually. So the bigger the window there, the more likely you have a big margin for error. So even if you forget to take your 2 paracetamol tablets and you take 2 of them later, you'd probably still be fine. But if the therapeutic window was very small, like the toxic dose for paracetamol, it's not, but let's say it's 1 gram, and the therapeutic dose is 500 milligrams. That means if you accidentally take 2 of them, you've taken too much and you could actually die. Does that make sense? So the smaller your therapeutic window is, the more dangerous the drug becomes. So we have a few examples of drugs with small therapeutic windows. The one that you'll hear about the most in work is digoxin. Digoxin is amazing at the right dose. At the wrong dose, it's very deadly. I hope this is making sense. Making sense? So generally speaking, drugs with very narrow, very small therapeutic indexes would not stand a chance of actually getting registered anymore. So we don't register drugs that don't have a very wide therapeutic index. Actually, I heard stats that also said that drugs like aspirin would most likely not be registered in today's life. It's only registered because it was registered those many years ago. If you have to apply for registration today with aspirin, you would probably not be able to do it. So aspirin is not safe enough. So does it give you an idea of how safe most of the drugs we actually are using? Most of the drugs we're using are actually very safe. To mess it up, you really have to not pay attention, but I didn't say that. Anyways, I think HalfLife you guys understand already. HalfLife is the time it takes for your body to reduce the amount of drug in your bloodstream by 50%. So if the amount of drug in my bloodstream is 1 gram now, and 3 hours later it's 500 milligrams, it means my half-life of the drug is 3 hours. So I'm measuring the amount of drug in my bloodstream, and I'm saying that this is representing the total amount of drug in my body. So if I measure it now and I measure it 3 hours later and I can see that half of the drug is gone, it means the half-life of a drug is 3 hours. Making sense? Okay. So generally speaking, we dose drugs according to this half-life. So if the half-life of a drug is 17 hours, we probably dose it once a day. If the half-life of a drug is 8 hours, we probably dose it around 3 times a day. If the half-life of a drug is 3 hours, we probably dose it around 4 times a day or 5 times a day. Does it make sense? So we use the half-life to guide our dosing. If the half-life is very, very long, like 3 days, we probably dose it only every 3 days. Happy? Okay. Now, as we are taking a drug, let's say, I wish I had my laser here. Let's say we're taking a drug with a half-life of 24 hours. Let's just make it 24 hours for simplicity's sake. So, if I take a drug now, 1 gram, 24 hours later, the 1 gram is now 500 milligrams. Then I take another 1 gram. Then after another 24 hours, what will my level be? it'll be a bit higher. And the next one will be even higher, and even higher, and even higher. So what happens? Where do we plateau? Where does it plateau? Where do we not get more effect? So this we call the steady state. So generally speaking, after 4 to 5 half-lives, our bodies go into this state whereby which the amount of drug we put into our body is equal to the amount of drug we lose through our body. So if you look at this slide, so we said that drug's half-life is about 24 hours. So 1 half-life, 2 half-life, 3 half-life, 4 half-life, 5 half-life. So every subsequent dosing I give the person would not result in a higher blood concentration. The blood concentration would more or less be the same consistently now, because the amount of drug I'm putting is equal to the amount of drug going out of the body. And that is steady state. We call this steady state. So what if the half-life of the drug is 7 days? That means you would reach this steady state only after 50 days? No? 7 times 5, 50 days, yeah? 55 days. So only after 55 days would you reach steady state with a drug that has a very long half-life. Is it making sense? Is it making sense? So as we take a drug, we reach steady state. When we reach steady state, the amount of drug our bodies eliminate is the same as the amount of drug we put into our bodies. And this happens after 4 to 5 half-lives. I think the literature is actually 5 to 7, but doesn't matter. 4 to 5. 4 to 5. Making sense? I hope it's making sense. Okay. So what did I want to say next? Okay. That's steady state. What if